The question here that comes to mind, and I think you could see the circumflex also, who would, you know, from the audience, just a simple voting here, who would think this patient will need 2 stents versus one stent? Who says 1 stent?
For this bifurcation, huh?
Why?
So, and
Why?
who, 2 stents?
2 stents.
2 stents?
More.
So more.
That's
So we have
majority.
more people saying 2 stents, and I would say 2 stents also, but let's see what.
Me too.
You too.
No, me too. But
oh, thank you very much.
And this is the circumflex. You see, in this view, it was around 50%, 50 to 60%. Diagonal, we have 1 lesion here, 1 lesion here, and the critical lesion of the LAD.
So it's 0, 1, 1?
It's certainly 0 and 1. There is a plaque at proximal, but we could consider that. I'm not sure that at the site of the bifurcation, the ostium of the diagonal is diseased. The lesion is a little bit.
The lesion
distal.
is near to the ostium. The vessel is 2.5.
It's close to the ostium.
Okay.
So we can come back later. A little bit.
Is the pressure just when the wire exits, the radio opaque part of the wire exit of the guiding catheter. So now we are almost ready to do this normalization.
So this is the FFR wire.
Okay, we can go on the FFR now. Okay. We do now the normalization to equalize the 2 pressure. So once the normalization is done, I think it's now correct. We will advance gently the FFR wire through the marginal branch.
So you can see that there is no difference in pressure between the pressure obtained in the guiding catheter and the pressure obtained in the pressure wire.
Probably I am not in. Okay. Fermez la pression. Okay. Okay. Some difficulty to turn. Okay. Yeah. Okay, what is interesting is to look first at the pressure at rest, and we can see on the FFR that already there is no gradient at basal state. So normally it indicates that this lesion will not be ischemic and will not require any treatment. We will do the FFR, but when you have no gradient at basal rest, I think that in most of the case you don't have a FFR positive when you inject the adenosine.
So you can see the 2 pressure here.
Bruno, just
and
explain.
Here you can see on the curve
the method that you're going to use
baseline,
for
there is
administering
no
the
gradient.
adenosine, which there are many different ways of administering this device, this drug.
Okay. Here in our cath lab, we use the intracoronary injection of adenosine. In other cath labs, sometimes they take a permanent EV infusion, but here we use an intracoronary injection, and we use for the left system an 150 microgram for the left system, and around 80 to 100 microgram from the right coronary artery. So the step now is to inject the adenosine, 150 microgram. So I will now flush.
So this is the flush.
And now we will see the measurement.
So it looks like 0.85. So that's obviously negative in terms of the FFR. In terms of the mode of delivery, it's perfect in this situation where you're really assessing a single focal lesion in a coronary. I guess the proponents of the peripheral infusion, which I have to admit that we use from at my base camp is if you have an ostial lesion, it's quite difficult to assess because you have to disengage the guiding catheter. And secondly, if you have serial lesions or a diffuse vessel and you would like to do a pullback, then that's the other reason to use the infusion. But in this situation, it's perfect. And the lovely thing is the consistency of the result. You know, we've got bang on 0.85 twice, which to me says leave well alone.
Yeah, I think it's very interesting to see that first the FFR is negative. We don't have to treat the lesion. What is interesting is the simplicity of this measurement and also the reproducibility of the measurement that makes it very interesting in clinical practice.
So now we have to think about the main course.
Yeah.
I was looking at this.
So maybe we can come back to this FFR evaluation. There was a question there on the FFR, and so you saw the way to do. Have you any question, any comment? Can we have a light on, please?
Jean,
Yes.
why did you frame this artery? Did you think from the start that this is an intermediate lesion, despite the fact in the QCA could be critical, or you frame any side branch in multivessel disease?
That's a good question. How to use the FFR? There's two ways. That is, there is one way to say, okay, I will use only when the lesion is around between 50–70%, what we call angiographically intermediate lesion, and we will try to be sure, confirm, yes or not, this lesion is significant hemodynamically or not. This is the first way. The other way is to say, okay, this patient has multivessel disease, and we will check all the lesion by the FFR, and we will treat only the hemodynamically significant lesion. This is the other two ways. Personally, I will be in favor of the first option, that is to use FFR when we have a depth on this intermediate lesion. But when the lesion is 80–90% angiographically, it's true that it's not, we do not lose time to do it, but why to try to cross a critical lesion with this wire, which is not evident to advance, the torque of the wire is a little more stiffer like compared to the conventional wire as BMW wire, for example. So why to take the risk to have, this section with the tip of the wire in the critical lesion? This is, for me, I cannot understand that.
The second, any fallacies of false negative for FFR, for the dose of adenosine, for the vessel, for the wire, for what do you think?
I think there is a good now correlation, and we know since the first studies on FFR, we have a good correlation between what we see as functional evaluation and the correlation with the clinical outcome.
No, I mean for the techniques, for the drug, because it's sometimes it's depending upon the wire, upon the adenosine, upon the injection, upon the connections.
Yes, but now the protocol is a standard protocol. We use close in all the center the same protocol. What is important, what we see at the beginning, if you have to equalize the pressure, of course, in order to avoid a bias in the calculation of the FFR. This is the first point. Be sure that before starting we have the two systolic pressure totally similar. Then we have to cross your lesion. Be sure that the point of your distal pressure hole is distal to the lesion, of course. The third point is a good, and they say during this case, a good indicator is the presence of the significant baseline gradient. If you cross the lesion and if you see a gradient more than 10 millimeter mercury, this is a very good point. In this case, when you cross the lesion, there was no gradient, pressure gradient on the baseline. So there is the very few chance, very low chance to have a positive FFR. The other point is the injection. The injection of adenosine could be done via intracoronary injection, and we inject around 100 microgram. It's variable from 70 to, but in fact the dose does not impact very much on the gradient. And this could be suitable for the assessment of the single lesion in the vessel. But if you have a diffuse disease and several lesions of the vessel, you need to do a pullback. And to do that, you have to use the intravenous infusion of adenosine. And then we do the pullback from the distal lesion to the intermediate lesion, from the intermediate lesion to the proximal lesion, etc., and from the proximal lesion to the guiding catheter. And then you can measure the gradient for each step of the vessel. And this is the second way to use the FFR. Other question concerning the technical point of FFR? What is interesting, and this was perfectly shown during this measure, is the repeatability, that is the consistency in the result. They took first check 0.85. They redo 0.85. If you redo 10 times, it should be 0.85, 0.84, 0.83. But it's really consistent in the this is maybe for me the most interesting thing. That you say when you can do one check, you'll be sure that the second and the third will be exactly similar. Other comment?
I just wanted to see who has FFR available in his cath lab. Who does not have FFR and wishes to have one? So, okay.
And for those who have FFR in the cath lab available, are you doing FFR in daily practice? Or just for research or for, are you doing in daily practice, FFR? For intermediate lesion? Okay. FFR in?
Papa.
Sorry, I can't understand. Papaverine. I have no experience. No experience.
We use intracoronary. We don't use intravenous.
Yeah.
But I guess intravenous is very important, and as you said, when you do pullback, or if you have an osteal lesion, because an osteal lesion you cannot be sure that you do inject all the intracoronary lesion and gets into the distal bed. You see, if you have an osteal lesion, your guide catheter will be out, and you will have difficulty in using we had difficulty in using intravenous because it needs a very huge dose of adenosine. If you mix it, I mean, if you only use adenosine for SVT, for SVT, the 6 milligrams ampoules, that's not good enough to mix for IV infusion. Did you have that experience? Because you need a much higher doses. So if you use the ampoules, you will finish all the ampoules in for one case to mix up the IV infusion.
So we can, if there are no more comment, we can move to the. Sure. We will see one more case of FFR.
Lesion earlier, and I guess there are a few issues. The first is, do we believe that we can treat the LAD without covering the diaphragm?